Hello, everybody.
Hello, everyone. Yes, the microphones are working. We have water. Good. Okay. So, yeah, welcome and hello to everyone. Thanks so much for coming tonight. We have such a treat tonight with Dr. Nighat Arif, who I will be calling Dr. Nighat, because
I said she doesn't need to do that. I've said to her, Nighat will just do. Fine.
Well, that has a ring to it, doesn't it? So what I'm going to do is just do short introductions, first of all to myself, to explain why I'm here doing the interview, and also about Dr. Nighat. So here we go. So the reason that this resonated so much for me is that, resident of Tring for 25 years, by the way, I spent the last 20 years of my professional life working in central government on policies to promote better outcomes for families, to help them thrive in the longer term. And female health is absolutely key to that, as I'm sure you would all know. And so the truly inclusive approach that Dr. Nighat has taken in the book also really resonated with me, because that has to inform all our services for families now. And there was something I was just saying a moment ago. I worked when I was quite young for something called the Women's National Commission. And that was a body that the UN required all its member states to set up, representing a wonderful breadth of women, all sorts of various faiths, occupations. And they advised government. Now, this was, a good, 30, 40 years ago. And if I could see some of those women now and show them this book, The Knowledge, they would be so, so touched and so excited that it's come to this, out of the shadows, women's health. So that's a little bit about me. But Dr. Nighat, so a very, very experienced and respected GP.
Oh, thank you so much
in Bucks. And a medical educator and communicator, which is so much what this book is about. You also train GPs and speak regularly at international conferences. So you're known nationally and internationally, and I'm sure many of you will have seen you on Breakfast TV, because you are the doctor on This Morning and BBC Breakfast, not to speak of social media, of course. Anyway, I've just selected a few things to give an indication of your achievements, but no time to go through them all. So you were nominated for the Bevan Prize, the National Prize for Health and Wellbeing, to acknowledge your exceptional commitment to it. You've very significantly increased the awareness of the menopause and women's healthcare in the Black and Asian communities. You've presented your clinical work, you were just telling me, on the menopause at the parliamentary committee that was reviewing it not so long ago. So your voice is heard in high places. And you worked with Team Halo, the United Nations initiative to bring an end to the pandemic.
I didn't do it on my own. That sounded really grand when you said that.
Well, you also presented at the G7 Global Vaccine Confidence Summit, which led to an honorary doctorate in science at London City University for Women's Health, Public Health and Wellbeing. I could go on and on, but I'll pause there. But now,
thank you.
Yes. So now you've written this book, The Knowledge, which is follows your passion, I think, to promote a real understanding of female health. It's divided into three essential parts about puberty, the fertile years, and then midlife. You cover a vast range of subjects, many of which have been in the shadows and things which people would only whisper about. And that's how you really cope with periods at school. For instance, pregnancy loss, vaginal dryness in the menopause years. You're bringing it out into the open in such a healthy way. And I was saying, if only that had been available when I was 14 or younger. And when my mother passed me a pale pink booklet, very, very short, just quietly and discreetly, my dear mother, with the best of intentions, but without much follow-up. And my goodness, for the young girls and women of today to have this, it's a different story. And I'm very happy for them. So there we go. Very timely as well. The government published a 10-year strategy on women's health just last year. You advised on that, of course. And they made the point, actually, that we know that women on average tend to live longer than men. I hadn't appreciated that women on average spend significantly a bigger proportion of their lives experiencing illness and disability than men. So, you know, so much to put right. So frankly, I think you know where I'm coming from. Every household should have a copy, for men and women.
I'm taking her everywhere with me, just so she can say that.
You should, you should. So what I will do is I will ask Dr. Nighat just a few questions, and then absolutely open it up to yourselves. So do think about what you would like to ask her. We have, you know, almost a full hour for that. So if I can start, I think it would be great to hear about the process that you went through. You were a busy GP. We know what the life of that can be like, working away locally, and then the process by which you came to realise that actually much more needs to be known out there, and that in fact there's a case for a comprehensive handbook to reach everyone. So if you could take us through that, focusing on the purpose.
I think, firstly, I'm so happy to see so many people. My son is here, he's 12 years old. And driving here, because I work in Edlesborough and at Pitstone, and I said to him, I don't think anybody's going to turn up. And I recently did a book signing where only 3 people turned up, and his response to me was, don't worry, mother, you've been humbled already. So I think that life throws you lots of humbling situations. And the greatest being is when I came here, actually in Cheshire at the age of 9, not speaking a word of English. And when you become the migrant child who speaks English for the first time, you end up becoming the translator naturally within your family. So I was the translator to my mother, who needed support from her GP in Cheshire about period issues, about, God forbid, other women in the community who had miscarriages, women who had menopausal symptoms, chest pains that we could never get to the bottom of, aches and pains or arthralgia that they would always complain about, but would never have the words to be able to explain it. So 9-year-old Nighat was translating issues for the GP, but not realizing what she was translating. And then it came to nearly 40-year-old Nighat in her general practice surgery in Tring, going, oh my goodness, I'm still doing the same thing. I'm translating women to understand their own bodies, which is something I thought was so open. We've got Google now. You can literally Google anything or see something on TikTok, but actually none of it makes sense. And it's so much misinformation out there about our own bodies. And it's so much part of it is hidden as well. There is so much taboo and stigma. So when it came to writing the book, it was essentially, I thought, I want to give women a recipe book about their biological journey. We don't just end up in the menopause or end up pregnant or end up going through periods. Actually, we transition from the moment we are born into puberty, then into our fertile years, and then into our menopause and beyond. But the men in our lives are just as important as part of that conversation. We're not just by ourselves. And then what I picked up in my decade worth of work as a gypsy. So for those that don't know what a gypsy is, I'm one of them, just so you know, which is essentially a GP with a specialist interest in women's health. And this was back, if any of you guys can remember, Tony Blair was our Prime Minister, yay, whether we like him or not. He said education, 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 which was absolutely right. So I got into medical school from the Misbourne School. I went to Bartholomew's Hospital Medical School to do my degree. And then the next thing he said, once I became a GP, was he was like, well, we can't get people into secondary care, into hospitals, because the waits are so long. So GPs are prime examples where you could train up doctors to have a specialism in that area, because 52% of the population at the GP practice are women. So we were like, Tony Blair, you're absolutely right. Can we have some money, please, to go and learn? There was no money. But we went off and studied, and I was one of those individuals that went off and did a specialist training. So I realized decade on that I had all this knowledge that I could put into a book that women in their households could have that conversation. So it was essentially the daughter, the mother, and the grandmother who I carry with me, because they are the women that come into my consultation. And often, you know, the sort of daughter will go, I never spoke to my mum about her periods, but now I'm 16 and I want to talk about my painful periods. Or a woman in her, you know, who's 50 going, my mother never spoke to me about menopause. And I realized that even in households, we walk around in silos, not having these conversations, but going through our symptoms. Wouldn't it be brilliant to have it in one place where you can just have that conversation?
So can you paint us a little picture about what success of this book would look like out there in communities and the way in which GPs are behaving, interacting and so on? What would you really like to see out there?
Do you know what? It's not even a huge plan that I have. I have a really lovely quote on my wall, which is from Colleen Hoover, who's a writer and a poet. And she writes about women's pain, and I see women's pain day in, day out. I've done a coil clinic this morning, so you can all put your legs together. Inserting marina coils and copper coils and contraceptives is no easy task. Everybody has different pain gauges, and it's a difficult time. But it doesn't last very long. And then I've got women who have had pain because they've had a pregnancy loss, and then women on the other side who are now having, pain having sex. So she writes about women being in pain, and she wrote, "My grandmother went through this, my mother went through this, I'm going through it, and I'll be damned if my daughter goes through it." And I think that quote I carry inside me, because it is essentially, if this book, even once I'm long gone, someone said, I was able to get my diagnosis for endometriosis and it didn't take me 7 years and affect my fertility, that would it, I'm happy. That's it, it's a really small request.
That's what we want. So, so in the book, you address yourselves to women in all sorts of circumstances. So, trans women, LGBT couples who want to adopt a baby, those with different skin color types, and you were telling me, the pitfalls of doctors not understanding what certain diseases look like on different colored skin. So you address them all. But it is fundamentally for all women. This is just good inclusivity you're doing, isn't it? So we mustn't think, perhaps your regular woman who, it's not for them. It's for all women, isn't it?
My worry always is with inclusivity and diversion that they become buzzwords without actually practically being available, and those spaces and those conversations aren't available for you. And I'm a woman who's South Asian. I speak Punjabi and Urdu. I wear a hijab. I'm dyslexic. So there are areas and conversations which I've always been exempt for. Having dyslexia, I was never the brightest in the class. And then being a hijab woman, I'd walk into a room and they'd assume that I'm there to make them tea. And that has still happened to me up until about 6 weeks ago, again. So I think that also just being a woman, actually, a lot of women will understand this. The minute you go in, they just assume that you're there to take on that maternal role, and that is the job that you have. So where do you find inclusivity in that and actually show it? So in this book, I was really careful that I wanted different skin tones, but also women's bodies are real bodies. Like, it's okay not to have a thigh gap, by the way. So just so you know. And it's okay to have like bingo wings. That's normal as well. It's okay to have stretch marks. And it's okay to have like examinations of different skin tones and how you do vulval examinations. So things that we should be doing ourselves. But there's a really funny story. I say funny story behind this picture. So when I went to my publisher, so this is a black vulva for those that can't see in the back. There is just one gentleman at the back, I can just see, he's looking at this going, what is this? I do apologize. All right. I like you already. And when this was made, when I was putting this together, all the writing was on the actual picture. And it went to the printers, and the printers came back to me and said, oh, Dr. Nighat, could we possibly make this lighter? Because then you can see the words. And I said, it was 2022 at the time. I said, it's 2022 and you want me to make the picture lighter? Bearing in mind, all medical books that I've ever read never had a vulva of black skin tone. And so I said, well, why don't we go around the picture? And they said, it'll take up more space. And I said, as a woman, we need to take up more space. I will happily let you take up more space. And I think that's the whole issue that we have as women, that when it comes to inclusivity, we actually talk about it, but we don't actually do it. These are these buzzwords. So we don't want women to be in that space, and we are excluded from a lot of conversations. Hence why, for the first time globally, there is the Women's Health Strategy to make sure that we tackle that. But even that is a 10-year strategy. So I wanted to say, well, let me take the first step and experiment with that. and let's take as much space as we need, guys, as much space as we need.
So one thing I really notice in the book is that obviously it's addressed to girls and women primarily, but you say that you want to inform girls and women so that they can understand better their grandmothers and have those conversations you were talking about, perhaps their aunt, maybe their sister, their older sister, what situation she's going through, to unpick it all and demystify it. You also talk about how it's important that boys and men understand something of this, so that they too have a better understanding of the women and girls in their lives and how they can support them.
Yeah.
Do tell us more about your thinking on that.
And again, it came from my own experience. When I started my periods, my mother just handed me really thick pads and just said, "That's it." You know, the white company, those thick ones. You guys remember those? So it was about 14, 15 when I remember when the school matron said to me, "Oh, there are pads with wings." And I was like, "What? There are pads with wings?" It was a game changer. But that conversation was never had with my dad. And the statistics show that 50% of girls are really embarrassed about talking about periods with their dads. You know, that's your dad. And I can understand that as well. I'm a mother to 3 boys. So I am the only woman in the house. And having those conversations, I realized it's got to change, because my boys will have daughters. They'll have at some point, if they choose to, partners at some point if they choose to. But also I want to have a relationship with them as well, so they understand that this is a natural biological journey that we go through as women. Men just transition once. They go through sort of, you know, birth and then puberty, and that's it. Unless you say midlife for men, I mean, that's different. Or man flu, sorry, I do apologize to them. But women, we have these distinct transitions, which are a normal part of our biological journey. And it only comes by making sure that we firstly allow men that sort of insight into us, and so it's not our own problem that we hold on to it. And secondly, that we break the shame ourselves and say, you know, I'm so happy with that gentleman saying, "I know exactly what that is, that's a vulva." And we all had a giggle about it, but that's so great, because it means that there is no shame or taboo. When the book came to the house, my father is the imam, so I'm literally the priest's daughter who talks about vaginal dryness, which doesn't go down very well sometimes. Especially when you go to the mosque and you show them what a coil is, and they're like, "Get out the mosque." And so the book came, and my dad just saw the fact that his name was at the end of it, Arif. I still got my maiden name. My mother sat on the sofa across from him, and in Punjabi, she was like, "I'm so happy you've got a book. This is amazing." She opened it up to the page with the black vulva. She looked at me. My father's so excited to have a look inside the book. And she just looked at me and she goes, "Darling, couldn't you find something else to do?" And I went, "This is my clinical work." And my father said, "Can I have a look? Can I have a look?" My mother just went, "It's not for your eyes." And I said, that was the first conversation, nearly 40-year-old Nighat, who had that conversation about normal biological anatomy, our breasts, our vulvas, our thighs, pregnancy, with my father. And then I realized this is stuff that I do, but I do it behind closed doors. We do a lot of stuff behind closed doors. And actually that just perpetuates the disconnect, and we work in silos with the men in our lives as well. When actually in my consultations, I've never come across a partner, a son, a husband, a boyfriend, or any male, even a colleague sometimes, who isn't there in my consultation room because they genuinely love or worried about the woman that they've come with. Men adore the women. You adore your mum, right? Yeah, see? So, of course, they have to be part of us. They have to be, because otherwise change doesn't happen.
Absolutely.
And I made him say that.
Should just say, the man at the back is my husband.
Oh, hello.
One of the best feminists I've ever met. It's true. So the book's for girls and women, but you also do direct some of your remarks absolutely to GPs and other healthcare professionals.
Yeah.
Here, and as I said earlier, you train them. Can you say a bit about how that is going to sort of complement our own enlightenment by reading it?
In medicine, it's so fast. I have 10 minutes per patient, and I have very even shorter time to train colleagues in my GP practice. And I've always had an open door policy, regardless of how busy I am, because sometimes the junior colleagues, we do unfortunately, like in any organization, have a hierarchy. The senior you become, the more remote you become from the younger colleagues at the practice. Although I'm always surprised because I make TikToks in my surgery, and my younger trainees are like horrified by the fact that I do that. And I just thought, oh, maybe you're younger, you'd want to do social media. But I think also when you are trying to teach, it can be really difficult to do that. And I thought, if I could put something in a book form like this, that actually, the point isn't that there is Dr. Nighat everywhere. The point is that every single one of my medical colleagues, even if they don't have an interest in women's health, have a resource that they can turn to. Because at the moment, we don't have one, unfortunately. We don't have women's health, which is part of our training, believe it or not. You have to go away and study, you have to go away and train, and that takes time. I've spent countless hours, nearly 10 grand of my own money, away from my children, long days, long clinics, honing in my skill. And you can't just pass that on organically, unfortunately. Someone can't just watch you do it. So in medicine, we have see one, do one, teach one. And in this, I thought, I'm going to reach out to my colleagues amongst all of this, because they also might not have the women's health background, because as GPs, the structure of our education is set to be that you're generalists. So you just become generalists about everything. There are certain focuses that we have, so heart, lungs, bones, but actually women's health, the fact that our hormones, how does our hormone affect us, is not really properly taught. Nutrition isn't properly taught.
I'm very shocked to hear that. I didn't know.
And it shocks me as well whenever I say it, because I just think this is where we are, and it's 2023. And when we know that 53% of our population in our surgery is going to be a woman, and 100% of women who go through, who have periods or will transition into perimenopause and then menopause and then beyond as well. Whereas in my 10 years as a women's health expert, I get every year taught about resus and how to do resuscitation for someone who's fallen and collapsed onto the floor. I've only seen one resus patient that I've ever had to assist and do basic life support. But every year I go away on a day to learn about basic life support. And I'm not demeaning basic life support, it's very important. But imagine the amount of women that I see who come in with period problems or perimenopause or want to discuss HRT. It's unfathomable, and this is a situation that we've got ourselves into because the structure of the training. So in my book, I'm also reaching out to my colleagues in a hand-holding way to say, look, you don't have to be a specialist like I am. Maybe this will give you some hints and tips of how you could manage a patient if she came into your room having had a miscarriage, or a non-binary couple who are planning to have a baby together, or someone who's transitioning from female to male and is breastbinding. How do you tell them how to do a breast examination and check for lumps? So all of that conversation only happens if we as doctors teach each other, unfortunately, and that's how medical training mostly happens.
And although I think you said you held your breath for a moment, actually you've had some great feedback from your fellow professionals about the book.
I was mortified when I was writing this. So I wrote this book going, this is essentially a window or a door into my clinical room. Like, what's written in here is 99.9% what I do in real life. So even the humor in there, that's me. That's what I do. I joke about it a lot. And I think you have to have a sense of humor, because as women, there is lots to laugh about our bodies and what we go through, and all the lumps and the bumps and the stretch marks and the hormonal changes that we go through. And I was suddenly thinking, gosh, my contemporaries are going to read this. They will see what I'm like as a doctor, because most of it I do behind closed doors, and nobody can see what you're doing with the patient, and it's just a patient-doctor confidentiality. And actually, it was my contemporaries who've been the kindest. So Dame Leslie Regan, who is the ambassador for the Women's Health Strategy, actually got my book, read it in 2 days, phoned me and said, when you do your book launch, I'd like to host you for the book. Wonderful. And I just thought, oh my God, this is the country's ambassador for women's health. And Rani Thakur, who's the first, well, she's the second female president, but the first woman of colour, which is incredible. She also was there at Marion Holiday from the Department of Health. So I've had lots of people who've been incredibly kind about my book, which is really lovely, actually. And I was always scared. I'm still scared. Every single time someone reads it, I'm like, oh my God, are they going to like it? But I think that's the imposter syndrome with me.
You mentioned your humour, and I really enjoyed that, because it feels as if you are speaking directly to the reader, and you are a little bit funny around the edges, and you nudge us, and you say, well, that's what you do need to do. So off you go. And it's very engaging, because you feel it's a bit more of a dialogue than a dry textbook that's giving you the facts, and then you make of them what you can. It's a helping hand, I feel.
And that was done on purpose, because I don't know about any of you guys, but when I was about 15, 16, I was again given that book, but it was just so patronizing. And there are a lot of books out there that are still very patronizing. And actually, in 2 weeks ago, I was asked to look at the guidelines for urinary tract infections for women. And I kid you not, the advice is wash from front to back. You tell a woman how to wash herself as the treatment for UTI, urinary tract infections. And it's 2023, and it was 2 weeks ago. And I rarely get angry, but honestly, my heart sank, because I thought, we are still teaching women, after sex, go and have a wee, wash, make sure that you don't get stool on your vulva. Don't wear skinny jeans. Don't get yourself too sweaty around your groin area. Drink lots of water as the treatment and prevention for UTIs. No mention is there the fact that actually you need to consider making sure that we need to consider antibiotics and the length of antibiotics and the right antibiotics. We need to consider the level of hydration that you have. We need to consider that your hormones will change, which means that the lining around the vulva will change as well. So you might need topical vaginal estrogen. Where is topical vaginal estrogen mentioned in the current guideline? Nowhere. And I think that's because when you are patronizing, unfortunately, when it comes to women's health, we just assume that women don't know their bodies. I'm telling everybody in here, you know your body better than anybody. I've done it for 15 years as a doctor, but my patients' lived-in experience, honestly, still today, I say outranks what I know. Because you guys are actually going through it. My patient in front of me, their lived-in experience of dealing with their problem is informing me and educating me. And that is where we need to sort of start finding our voices again and be able to say, no, I need to do this. So in my book, there's a lot about self-advocacy. How do you speak up for yourself? How do you actually say that this is what I want? And I had a patient who came in a couple of days ago, and she said, my friend took your book in, put it on the GP's desk, and said, this is what I'm entitled to. And the GP went, yeah, I know, Dr. Nighat, that's fine. And I think that it's about sort of that partnership, because at the end of the day, we just want you to be well. Because if the woman is well in the household, then the household actually is well. And I'm always reminded of this case. So a while ago, when I used to work in Slough, I had a Pakistani gentleman who always had high blood pressure. He came in to see me, his blood pressure was awfully high, I couldn't manage it. And it came to our 7th appointment, he'd sort of become confident to talk to me. And I said, is everything okay at home? And he said, my wife just doesn't sleep. There's no intimacy, she's got hot flushes and night sweats. And I said, oh, what's her age? And he went, she's 48 years old, but she refuses to come to the doctor. And I said, tell her to come and see me, but come together, because I think it'll be really important to learn about what's going on. It could be that she's perimenopausal. She was perimenopausal, got her on a treatment plan, but lo and behold, his blood pressure came down. So that just shows how important it is for women to be looked after, because they are the glue of the household.
So I'd like to open it up to questions in just a moment, so please do think of any you'd like to ask. But I'm very drawn to this bag of tricks that you've brought with you.
Do have a bag of tricks.
Is this the moment perhaps to go through one or two of them, or would you like to leave that till later?
No question is off limits, by the way, so please do not be embarrassed to ask me thing. I was joking to a friend of mine. I said, this is probably the quickest you'll see a GP in a while. So I've got quite a lot of, I'm so, like, it's so true. But I've got lots of bits and pieces that I wanted to show you. So if you want to ask me about HRT, ask me about HRT, about coils, ask me about coils. If you want to ask me about periods, ask me about periods. But we'll take questions. And
sure, and you've got the apparatus. Great, okay. So we have an audience online, so we will factor them into any questions. But first of all, any questions from here? Oh, lady at the back.
Could you wait till you've got the microphone, please?
It's not working. Oh, there we go. There's been a lot in the media about HRT and people commenting that, you know, we're all crazy because we want to just stay young and we should just accept it and it's part of life. And I mean, have you noticed in your practice an increase in the number of women that feel that they can come and ask advice? Because it's been a lot in the press and Davina's always on TV talking about it, which I support, you know. Have you noticed that in your practice?
I definitely have noticed that women are far more empowered, and not all of them want HRT. In fact, they just want more information. And I really don't like the narrative that goes around a lot that, you know, we're trying to be younger. We're not. We're essentially just asking for our hormones that are depleting. We want them back. We have to think of menopause as not just, oh, well, it happens to every woman as she's just transitioning and it's a normal part of life. There's a group of women, 1 in 100, that will go through it early, so premature ovarian insufficiency. So we've got to weed all those out. And the fact that it's only 1 in 100, I think that means that we're not picking them. There's probably more than that. There's probably 10 in 100, but we just don't know. There's also a group of women who have surgical menopause, so we remove their ovaries and their womb for whatever reason, fibroids or endometriosis or adenomyosis. And there's a group of women who have been now going through some sort of therapy, and that has actually put them into chemical menopause, and they need also their hormones. So we've also become quite fearful of hormones as a narrative that's been fed out there, particularly estrogen. In my years of work, I've realized that estrogen is this lovely lubricating hormone. It lubricates everything that we need. And we notice that because when we menstruate, so I'm 39, I still have periods, just a week before my cycles, I know that I become really lethargic, I want lots of sugary foods, I become tired, a little bit of brain fog sets in, I become slightly clumsy, and then maybe a day before my period, I get sort of maybe a slight headache and I feel a little bit more thirsty, and then my period happens and I'm okay. Because we know in the luteal phase, that couple of days before you bleed, that your estrogen drops. So it's not just the fact that our estrogen drops just when we approach perimenopause. Our estrogen is dropping a little bit every month if we do have a monthly period. And our estrogen drops again after pregnancy. So when we're breastfeeding, in order to breastfeed, our estrogen drops. So that's when, if you get a recurrent itch or something that doesn't go away and you've done swabs and it's not thrush, it's vaginal atrophy. So we need to be giving women that time, at that time, not anti-thrush medication. We should be giving them vaginal atrophy, something like Vagifem. So this is topical vaginal estrogen. It's Vagifem. It's a little tablet at the end. It only works locally. If you're breastfeeding, you can have this, once we know that it's not thrush, and it doesn't go to the baby, and it literally just lubricates the tissues around the vulva and the vagina. Exact same thing happens as you approach perimenopause. Now, in Black and Asian women, we know that actually we start from the SWAN study that was done in 2022, about 2 years or 3 years earlier into perimenopause than our white counterparts. So it's not that you're too young. So 40-year-old women, or 43, 45-year-old women who come in and say, I'm getting really sore, my last smear was very painful, I'm getting recurrent urinary tract infections, we need to think about replacing that hormone back for them. So it's all about replacement. It's not about keeping you young or holding off youth. It's about replacing what your body needs, because it's this lovely lubricating hormone. Estrogen is what our immune system uses as an immune modulator. Estrogen is what our brain uses to allow the synapses to talk to each other. Estrogen is what our blood vessels around our heart use. So if we have a lack of estrogen, then actually we know that postmenopausally, so that's 1 year, 1 day without a period, and we will remain postmenopausal for the rest of our life. If we don't have estrogen, brings on worsening brain health, worsening cardiovascular health, worsening bone health. So it's all about how can I make you fitter and stronger, not for now, but for later if you wanted to go on HRT, but also educate you so that you can approach perimenopause and menopause, not for now, but in the next 4 decades that you'll probably be alive for. So I think that's the narrative now that I'm speaking to my patients about. So they're becoming more empowered, going, this is what I want to have the discussion about, because I want to live great in my 40s, but amazing in my 80s.
Thank you. Other questions? Yes, lady just there.
Hi, thank you so much. This has been really empowering and fascinating. And it's a question, I guess, for maybe like all of us, but it's a question around how can we influence the education system all the way through to increase knowledge about women's health? Because I know that when I was quite young, my mum was going through menopause and I didn't know what was going on. It was quite confusing to see your mum go through these changes. And I'm 30 now, and I honestly don't really know very much about menopause. So I just wondered what could all of us do to try and influence that change? Because I feel like our young people, maybe it's changed since I was at school, but it feels like there isn't enough conversation about this stage in women's lives.
Well, not to brag, but no, I'm joking. The first thing is the fact that you're here is so significant because you are the change. So you said, how can we have change? It's within you to make that change. It doesn't take one like silver bullet. It's a multitude of different things. What you learn, so whatever I put in here actually now is not mine anymore. My clinical knowledge that's in here of 10 years, which is currently what's available in the NHS, and some of it is what's available privately, is not mine now. This is my gift to you. Take it, share it with everybody around you, share it within all your groups that you know, take it and even make content out of it. You don't even have to reference me, I don't really care, because the most important thing is it's out there and you're giving evidence-based information to people. The other place that we're really finding an upflux of information is that actually the Women's Health Strategy has incorporated for the first time, next year will be our 3rd year into the Women's Health Strategy, making sure that we have women's health in our educational program at medical school. I know it sounds crazy that we're not teaching at medical school. So that's number one. We're also looking at the curriculum again. So we're looking at incorporating menopause. So in early 2000, just before, as we're in the height of the pandemic, it was incorporated into the national educational curriculum to make sure menopause is added there. So 16-year-olds are taught. But at the moment, we're trying to go, but boys and girls need to be part of that class lesson. And menopause needs to be talked about at school. But schools are, it's usually the geography teacher who wasn't at the meeting who's told, now you've got to talk about menopause. And he's like, what? So it's about how we can get that education program out. And the next thing that I'm currently working on is with Professor Joyce Harper, is the National Menopause Education Program. So we used to have, well, we still do NCT classes. Anybody went to NCT classes? And you'd go and learn about pregnancy. Well, we want something similar for free for menopause. So women from 35 onwards can do either hybrid online or in-person talks with somebody, doesn't have to be a doctor, someone who's just very passionate about menopause, and talk you through all the options, what you can do, because it's really not a scary time. Like NCT, okay, you might not hear all the horror stories about pregnancy, but actually it's about building a community. We want to do a similar sort of thing around menopause. So there's some exciting things that are going to come forward in that.
We were saying every school library, what I was saying, should have one, so that I'm thinking of the women in my life who I want to draw attention to this and indeed give as a present. And you know, a niece in a Hackney secondary school, and she will just love this. And you know, I'll make sure she speaks to her PHSE colleagues so that, you know, it's deployed.
It was done with purpose, because when I was writing this, my editor, lovely Pauline, who also lives in Cheshire, actually, she's a lay person. I hate using that because she's very intelligent and she's not lay at all, but she's not medical, she has no medical background. And so she would read my edits and she'd come back to me and say, what does this mean? What does this mean? So things that I thought was my bread and butter is actually not everybody else's bread and butter. So what's an endocrinologist? What are you talking about? Prostaglandins? What is that, Dr. Nighat? And then I realized actually I need to make it so it's so accessible. So actually in a household, that's the reason I did it. So it's the whole journey with the men involved, because you just literally need one textbook. It is literally that recipe book that everybody could use in the house and share it around. And hopefully it's not too embarrassing to put on a coffee table to have. And that's where I think that this isn't the most extensive conversation about women's health, but at least it's a starter to be able to understand just the basics, because we've even moved away from the basics, unfortunately. And there are, like I say, intersectionalities, marginalized communities, LGBTQ plus communities, Black communities, women who are affected by FGM, who are covered in my book, who aren't part of that mainstream conversation. Where do they turn? So it's about sort of having the skills that you invest in because you've taken the knowledge, and then sprinkle that around as much as possible.
It's something I found that some of the prehistoric books about women's health on my bookshelf are going, because it was quite a wake-up call. I'm behind the times, so you know it's bang up to date as well. Alison, I think you have someone.
Yes, we've got somebody online here who's 18 years old and has been diagnosed with endometriosis 5 years. Been campaigning for 5 years, finally got a diagnosis. She's been given a treatment plan of the mini pill due to the location of the endometriosis. Yeah. But she's reluctant to take that. And she wonders, is there any other form of treatment, or is it worth her trying to get a second opinion? She's 18.
So I'm going to do this answer in two parts. One is endometriosis. We think, because we don't know the cause, it's a lifelong condition. It's when the lining or cells similar to the lining of the womb get deposited into the pelvis and you get endometriotic lesions. Those endometriotic lesions over time can cause scarring, and if you get a lot of scarring, it can impact your fertility. But also those lesions within the pelvis, so around the tummy, around the bladder, around the back passage, around the rectum, can cause immense amount of pain as well. So at the moment, as it stands, we have no test or diagnostic way of checking for it, apart from doing a laparoscopy, which is a camera within the stomach. We put a camera in and have a look. And that currently in our area is about a 9-month wait, as I work in this area. So the fact that you, at the age of 18, have a diagnosis of endometriosis is number one tick, that you've got the diagnosis and you've got it early at the age of 18. The next is, as doctors, we are worried about two things. One is preservation of your fertility, whether you might not even think about children at the moment, but we need to. And the next is management of your pain, so you can get on with life. Like endometriosis pain is horrible, absolutely horrible, and it's horrific, and it takes you out and knocks you out for sometimes up to a week. So if you're having a period every 4 weeks, 3 weeks that you've got a bit of respite, and then a week you're losing. Imagine the amount of painkillers you're spending, time off work, fatigue from studying, being able to do activities of daily living. You've got to counter in that also is affecting your ability to function as a person. And so what can we do in regards to support you? So the next bit of my answer is we're very limited into treatments, unfortunately. Because we've got to preserve fertility, the only way to do that is to give you a long-acting reversible contraceptive. So that could be the mini pill, the combined oral contraceptive pill, the implant, so that goes into the arm for about 3 years, the injection into the bottom, that works for about 3 months. And even at the age of 18, it's okay to have the coil, but we have something called a mini coil, so it's not the big Marina coil. Well, I say the big Marina coil, this is what the Marina coil is, that's how big it is. But the mini coil, so something like JDES, can be very safely used for the management of the symptoms of endometriosis. It doesn't cure it, doesn't make it go away, but manage those symptoms, preserving your fertility and your pain. How do we manage that? So if the mini pill isn't working for you and you're not happy to take it, then you need to think of another form. And what I do with my patients is I offer them the most general thing that you can have, say the mini pill, that you take every day without a break, trial it for 3 months, and let's see if that works for you. Does it manage your symptoms? Well, if it doesn't, you can stop it and we can then go to another one, and decide another one. because it's all about trying to make sure those endometriotic lesions don't spread and get bigger. Because if they get bigger and you're getting scarring and adhesions, then we're into a bit of a problem area. So I would say to my 18-year-old patient, we know you've got the diagnosis. We need to really drill down why the mini pill you're not happy to take, but what is it that's affecting it? Dr. Arif, I can't remember to take it every day. Well, that's okay. Maybe we can consider the implant. You don't have to remember it. It goes in, stops your periods, stops you from shedding, stops the endometriotic lesions from getting bigger. So there's all lots of different options that we can try. Apart from long-acting reversible contraceptives, we don't have much else. So the women's health strategy is looking at always research, and I'm an ambassador for the only charity that looks at women's health, which is the Wellbeing of Women, and that's a charity that's been running for 60 years, and it does research. So in July this year, we actually funded the first research into a non-hormonal treatment and cure for endometriotic lesions. So it's something called dichloroacetate. It's a trial that's being run in Edinburgh and Birmingham currently. So I'm really looking forward to looking for the results of that trial, because it's a non-hormonal, and what it does is it actually treats the lesions and shrinks them. So that's the exciting bit, but we're not there yet.
Thank you. Do you have any other questions online?
Yes, I do actually. Somebody's saying, can you take HRT even once you've gone through the menopause? And is there one available on the NHS that does not involve animal products?
So definitely, yes, you can take HRT systemic. So systemic is something that's going to go throughout your whole body. What do I mean by systemic? So you've got a couple of options. So this is estrogel. We've also got synthetic versions. So they look like these. They're little tablets. And then we've got body identical progesterones called utrogestan. There's about 18 different combinations, by the way, that your GP could try with you. So the NICE guidance say that there is no end date to HRT. I had an 85-year-old who came in for a coil exchange because she was using her coil as part of HRT. And she was like, you'll prize my HRT out of my dead hands. And I was like, I know, I'm going to leave you with the HRT. I'm not going. So the coil can act as your progesterone component for 5 years, and then you can put on a gel or a patch. This is the joy of HRTs. They're body identicals, and they've moved on so much. Anything that's going on the skin bypasses the liver. We can move it away from the boobs, so your risk is much, much less. So I always say to my patients, whenever you're ready and you want to have HRT, let's have the conversation. We'll do the risk versus benefits and try it. Then this is really important. So this is localized. This is different from this. You'd have to use a year's worth of this to get 1 day's dose of this. So the dose equivalent is massively different. So this is localized topical vaginal estrogen. This is Vagifem, and this would treat things like vaginal atrophy. So vaginal atrophy is essentially a condition where you get shrinkage of the cells. Atrophy is that medical word, means shrinkage. This would prevent prolapses. This would prevent stress incontinence. So you know when we cough and sneeze in our 40s and 50s, and we have like an oops moment, as the adverts say, actually, that's wrong. Like, that's not normal. And it's because we lose the laxicity of our pelvic floor muscles. So the RCOG, the Royal College of Obstetrics and Gynecology guidelines are is topical vaginal estrogen can be given to women to help them do their pelvic floor exercises. I'm now giving it to women after having a baby. They've had a traumatic forceps delivery, or they've had a von Toos delivery, or they are larger, and they can't do their pelvic floor exercises. I add in, for however long they're breastfeeding, topical vaginal estrogen to help get that laxicity back into the muscles, to get that strength back in so that they don't get a prolapse in the future. Also prevent urinary tract infections. And you can be on this lifelong. There is no increased risk to breast cancer. There's no increased risk of clots. And even if you've had breast cancer or a family history of breast cancer, the data now is showing that it's safe to have. So my patients who are, say, on tamoxifen, I put them on Vagifem with consultation with their breast cancer surgeon. And patients who are on, say, letrozole, I give them a different form of it, which is a little bit of testosterone, which gets converted into a tiny dose of estrogen to help them with their vulva and their vagina. Historically, we've said to women who've had breast cancer, no hormones, nothing, don't do it. Actually, we've moved on far, far from that. So I give them DHEA if they're on lestrozole, so something called intrarosa. That works really, really well for even those women who've had quite, a history of breast cancer. So HRT is not scary. HRT can whenever you're ready.
Thank you.
Everyone's looking really surprised, like, really? Is that the truth?
So just looking for other questions from here. Got one at the back, yes, and then I'll come to you just over there, okay?
Hello, I'm on HRT, love it.
Yay!
Nobody's taking it away from me, but I do feel I'm on Duet, which I think was a very basic, low level. I'd like to change to a body identical, but also how will I find out if I need my dose increasing?
Oh, okay. Also, I've just forgotten, the first person asked, are there HRTs without animal products? Definitely there are. Body identical, so estrogel patches are not made with animal products at all, because they're made out of root vegetables and yams. Coils are not made of animal products. We have the old synthetic versions, which used to be made out of horse urine. And the Utrogestan, there is versions, the outer casing is made out of a slight casing, which I think comes from, the manufacturers are really sort of bizarre, because they say it's not animal product, but it's a similar casing that is derived from animal cells. So for some people that's not vegan friendly, but for some people that's okay. So vegetarians are like, oh, that's okay if it's just taken from cells to make the casing. But a lot of HRT now isn't made out of, especially the body identicals, of animal products. The answer to your questions, how do I know that I need to change your dose? Symptoms. Your symptom diary is the only thing. You know your body the best. If you come and tell me and say, Dr. Nighat, I'm on Duet and this is how long I've been taking it, I look at your dose and I say to you, right, what symptoms are affecting you? Hot flushes are still an issue, palpitations, night sweats. I want to kill my husband every day, not that you do, I'm just assuming. My mood and my irritability is annoying me. So your symptoms, I want to make sure that those symptoms aren't because of another diagnosis. We can't, as doctors, become blinkered and go menopause, menopause, menopause. So I want to know, is the fatigue because you're anemic, or maybe it's a diagnosis of diabetes. So a good doctor should always be ruling out other conditions. And then once we've done that, we go, actually, it probably is because we need to increase your dose. Then we basically tinker and tweak and tweak and tweak based on your symptoms. I don't do female hormone tests. It's a waste of money for women over the age of 45 because they don't mean anything. I know some doctors do estrogen levels, so they want to know the absorption as well. I've looked at the data from the British Menopause Society and also the International Menopause Society, and I'm not convinced because the data for absorption varies so much, and each lab is very different. I can send a sample to Stoke Mandeville Hospital lab and a sample to Luton and Dunstable lab, and I'll get 2 different readings for the same patient on the same sample, because there is no standardization. So actually, the way to deal with it is not by chasing numbers. You chase the patient. I want to listen to you and see what can I tweak for you. On average, if I see a patient and I start her on HRT, I say to her, you're going to see me for about 3 years. You might not like it, but it's going to take me about 3 years to tweak the dose, the type, the way you take it, when you take it, how you take it. Do I need to add in testosterone as well? Is it just estrogen? Do I need to think about the dosage of progesterone? So there's so many different variables, and unfortunately it's an art rather than exact science.
Thank you. So we've got a lady over here who was going to ask a question, and then I must go online for another one. And we need to press on. Time is short.
Hi. I just wondered if you could just talk a little bit more about the whole, if you start on HRT and you're perimenopause and still having periods, that idea of how long, or do you ever get to sort of the other side where you can have this lovely life without periods? Because I understand it keeps you having them, doesn't it? So
I'll give you my example. I'm perimenopausal. I'm 39. I know my son's here. Don't worry, you've heard this before. And my first symptom isn't hot flushes. My first symptom about 6 months ago was recurrent urinary tract infections. And I was like, I'm not someone who gets UTIs, and this is really bizarre for me. And then I have a coil in at the moment, but it's a copper coil and it makes me bleed. And so I was like, tampons are becoming slightly more trickier and they're sticking, and that's not like me. I recently taken up swimming, so because I want to get fitter as I go into my 40s, and I thought maybe it's the chlorine. So you gaslight yourself going, it can't be that, it can't be that. So I've done this to myself. And then I was in Sweden doing my global talk for a women's health conference, and I got a UTI on the day that I was going to give my keynote speech. And if any woman knows what that feels like, you feel absolutely rotten. And that's when the penny dropped for me after managing this and coping with this and going, it can't be true, for about 6 months. Came back to the UK, phoned my GP, who was a lovely locum, and said, I think I need some topical vaginal estrogen, please. I've been using moisturizers, but they're not doing the trick, and I think I'm perimenopausal. And so he said to me, you're too young. I was like, no, I'm not. And this is atrophy. And he just went, this doesn't sound like atrophy, I think it's thrush. And I went, I've written a book. But long story short is how do you plan for this natural transition? Because I'm transitioning. And so my plan is that in a year or so, is once I get my atrophy, is to remove my coil, put in a Mirena coil. That'll give me 5 years of my progesterone. And if I need to have estrogen on top of that for brain fog or palpitations, because I know I'm naturally transitioning, then I can have a choice of putting on either gel, or I can have a choice of putting on a patch and then adjusting the dose with my GP. And then I will naturally transition into that. And if you are still having periods and you're perimenopausal, you will naturally transition into menopause, which is 1 year without a period. So if you are perimenopausal and you decide not to have a coil because the coil will stop your periods, but say you say to me, Dr. Nighat, I don't want to have a coil, I want to have the patch and I want to have utrogestan tablets. Utrogestan tablets, you take 2 tablets, 2 weeks on, 2 weeks off, so you have a bleed. You will naturally go through that up until you're about 52, 53, which is the national average of menopause. Menopause is 1 year without a period. Post-menopause is 1 year and 1 day without a period. When you get to that, we just change the regime of this and get you to take it every day rather than 2 weeks on, 2 weeks off. So what we do is we just adjust and change the dosage of the HRT. We allow your body, all we're doing is replacing what your body doesn't need, but getting you to go through that natural transition, that perimenopause. Does that answer the question? Yeah.
So last question, Alison.
I've got a couple of little questions, if I may. One
very
might be a quick
answer.
answer is, do you discuss UTIs in your book?
I do discuss UTIs, vaginal estrogen.
Marvellous. And what helps with perimenopausal sleep problems?
This is so complex. So perimenopausal sleep issues are because of a multitude of different things. One is the vasomotor symptoms, so hot flushes, night sweats, which means that you can't fall asleep. Secondly, we know that our brain is programmed to take over the job of producing estrogen. So if you remember back to when you were going through puberty, do you remember that you got a bit of puppy fat? Why did you get puppy fat? Because our sex hormones, estrogen, progesterone, and testosterone, are produced through our fat cells. So then that puppy fat is there because the brain goes, she's got to the right age, she's got to the right weight, there's no other external stress, she's ready to have her periods. So that's why we end up then losing all that puppy fat, because then our fertility cycle begins. When you get to perimenopause, your brain goes genetically, she's now reducing the number of her eggs. So that means I'm not getting estrogen, but I need to make estrogen because it's this lovely lubricating hormone. But I'm also making melatonin, my sleep hormone. I'm also making serotonin, my happy hormone, cortisol, which is my stress, my dopamines. I'm also making adrenaline. Your brain actually makes so many of these hormones. So if the estrogen goes down and your melatonin, your sleep hormone, comes out of kilter, because what happens is your brain takes over and goes, I've also now got to make estrogen, but I can't make all of it, so I'm going to send a signal to the fat cells. Do you remember what you did when she was going through puberty? Can you do that again now, please? But now we don't want weight because we're in our 40s, we just don't want it. So you might find that you're doing whatever you possibly can and you just cannot lose weight. And sleep, the reason your sleep becomes affected and your weight also is because of that imbalance. So at perimenopause, it's so vital to actually look at your sleep really carefully. So the things that we can do is obviously sleep hygiene, which I talk a lot about, lifestyle factors, alcohol, because you might find that that affects your sleep, stress, anxiety, managing your hot flushes, so maybe it'd be HRT as well. There's loads of other things that we could do. So a very, very low dose of antidepressant can work really well. And also for my patients who have sleep issues, Utrogestan is a dream. This is so good because Utrogestan, which is a progesterone, it works on the GABA receptors within the brain. So you take this at nighttime and it knocks you out. And it's on purpose because your brain is getting some help from giving you back the hormones that you need. And so the brain goes, okay, I don't have to work so hard. This is why managing perimenopause is so important, because we cope with lack of sleep, we go on, we keep putting on weight, we don't look after ourselves, we're angry, we're depressed, we want to leave work. 1 million women are estimated to leave the work around perimenopause. We are irritable, we're angry, we push people away. You know, those conversations with your partners aren't going so great. The highest rate of divorce or breakdown in relationships is when women are going through perimenopause. And so you come to the end of it in your 60s and 70s, and now you find that because you're not sleeping, your blood pressure's high. So it's really important to manage this, and it's so easy to manage with a combination of ways of doing it.
What a wealth of information. Thank you very much. I just want to ask you, how do you manage it all? All these dimensions to your professional life you've spoken about, you know, BBC Breakfast one day, Tring the next, your GP surgery, and your family. How do you do it?
Oh God.
Anything that occurs, top tips.
Do you know, no,
it's always interesting to hear.
I get asked this, and I always think, do men get asked this question? And a part of me goes, probably they don't, but actually I don't get offended by that question. But I always think that when you are passionate about something, to me it doesn't feel like work. But also because I'm very aware that, and this is going to get really deep, but I'm very aware that we have a finite number of years on this precious rock that we live on. And it goes around. And I'm very aware that I'm very replaceable. If anyone tells you you're not, they're lying. I will leave my surgery and there'll be a younger, hotter, six-pack, hijab-wearing doctor there. And they are out there. She's probably been on Love Island. So I think that the thing is that my way of balancing things is just to go, I'm here for a finite number of moments, minutes, hours. I want to help, but then I move on. I'm very good at sort of handing the bucket over to somebody else and move on. And so the way I cope is to go, okay, if I could make a tiny needle of change wherever I am, even if it means, like somebody today is going, I never knew that that's why we put on weight around our periods. I never knew that. To me, that would be amazing, because they'll go away and share that with their community and be able to understand their hormones. And so I ask a lot of, the way I manage it all is because I'm so intuitively asking questions of myself and also asking for help from others to go, teach me, because I don't know enough yet. And so that means when I'm learning, I take everybody with me. My sons come with me, my kids come with me wherever I go, don't you? Yes, you do. And asking for help, it's a combination, late nights, long hours, tearful days in surgery because someone's had a miscarriage, things not going right. You don't become a doctor because it's a happy job. And nobody comes to see the doctor because they fancied a day out, right? Let's face it. And I know how difficult it is to see a doctor, and it's a precious commodity that we have. So the one thing that makes me keep going, doing BBC Breakfast this morning, podcasts, making my own social media content, and it's for free and it's out there, writing this book till 2:00 in the morning and then going to surgery at 9:00 and going, oh, this is what I need to write about the coil, so someone who's going for a coil isn't so scared, is because I think that the need is that I want people to look after themselves, because you literally save me time. So there's that selfish nature that if I can just give this to you, and it saves me some time, then that's okay. But also it means that it's a gift that you can just take and it's yours, and then share it with everybody else. And that just is the only thing that keeps me going.
Thank you. So thank you to everyone and to you. Thank you.
Thank you.
And I believe you're okay to sign some copies
Oh
at
yes,
the front
if
of the
anybody
church.
wants
So,
any copies,
yeah.
by all means, I will
the
be
next
more than
stage.
happy to sign you a copy. And thank you so much for coming to see me this evening, honestly. You made a tired NHS GP very happy.
Oh, well, a massive thank you from us. Thank you.
Thank you.